In this class, we're going to discuss factors causing mechanical damage to the skin, specifically the effects of friction, shear, moisture, and pressure. We're going to discuss the pathology, the clinical presentation, the prevention, and management of these wounds. And we're going to divide the discussion into two major sections. First, we're going to discuss superficial wounds, which are typically caused by friction, moisture, and superficial shear. And then we're going to discuss deeper wounds that are typically caused by a combination of pressure and possibly shear. First, let's define the terms partial thickness and full thickness. These are terms commonly used by burn physicians and plastic surgeons. Partial thickness means that you have partial loss of the skin layers themselves. So if you have a partial thickness lesion, you have loss of the epidermis, you may have partial loss of the dermis. But partial thickness lesions never extend all the way through the dermis. In contrast, with full thickness lesions, you have total loss of the skin layers. The epidermis is gone, the entire dermis is gone. You have extension at least into the fat, and you may very well have extension into the muscle or the bone. So we're going to start our discussion talking about partial thickness lesions. Now, partial thickness lesions, by definition, as we have already said, are going to be very superficial because they involve loss of the epidermis and may involve partial loss of the dermis. Go back to the fact that the epidermis and dermis together are 0.2 centimeters in depth or in thickness. So if you have a partial thickness lesion, you have lost the epidermis, you might have lost part of the dermis. It will be 0.2 centimeters or less in depth. Many partial thickness lesions have no depth at all. Others are like 1 millimeter or 0.1 centimeters in depth. If you look at these wounds, you can see this one has no depth at all. That's a classic partial thickness. This one is 0.1 centimeters. This one is about 0.05 centimeters. All of them very superficial because what have you lost? Epidermis and possibly part, but not all of the dermis. So first of all, a partial thickness lesion will be very superficial, very, very shallow. What will the wound bed look like? Well, it depends on how deep it is. Go back to the anatomy and physiology. The epidermis, when you take off the top layer, you expose that reproductive layer and it's bright red. So if your lesion is confined to the epidermis, if you have loss of the superficial epidermis, you will get exposure of the basement membrane and the wound will look bright red and moist with no depth. What if your partial thickness lesion extends into the dermis? Remember that the dermis is primarily composed of collagen, and collagen is white. So if you have a wound that extends into the dermis, the base of the wound will have a white appearance, which you see here. Also remember that the reproductive layer of the epidermis dips down into the dermis to line the hair follicles. So every place that you have a hair follicle, you'll have a little patch of reproductive basement membrane, which looks bright red. So when you look here, you've got a pale white ulcer base, but scattered throughout the ulcer base, you have distinct red epithelial islets. So it's white with little red bumps. You don't chart it that way, but that's how it looks. Now sometimes your hair follicles will be clustered so closely together that you end up with a bumpy salmon-colored surface. But if you look at all of these, they're all very superficial. They're all either bright red, white with pink epithelial islets, or a salmon-colored. There's no slough, there's no eschar, there's no tunneling, there's no undermining. So across the board, partial thickness lesions are very, very superficial. They have a viable wound bed that will either be bright red, salmon colored or white with bright red epithelial islets. If you ask the patient, they will tell you that this wound is painful. Think about what happens when you skin your knee, skin your elbow. You expose multiple nerve receptors. So these lesions are very painful to the patient. So they're superficial. They have a pink or white red viable wound base. There's no necrotic tissue, no tunneling, no undermining, and painful. Now there's another important consideration when you look at partial thickness wounds, and that is that the damage always occurs from the top down. So you're literally taking off skin layers. This is not an ischemic wound. These wounds are caused by some form of trauma, either repetitive friction, superficial shear, like when someone's drug along the pavement, things like that. Okay, so let's talk about common causative factors. Friction's a very common cause of superficial wounds. You see this every day in clinical practice. So sometimes you see abrasions where someone is rubbing against, say, a soft wrist restraint. You'll see blister formation where someone's rubbing their heels against the bed. Or if you're in an outpatient clinic, patients may come in with blisters on their heels from a poorly fitting set of shoes, pair of shoes. You might also see superficial breakdown on the buttocks in a patient who's incontinent from repetitive cleansing, or because the patient's constantly moving around in bed or constantly sliding down and being pulled back up in bed. What's the common denominator? Mechanical force applied to the surface of the skin. So friction's a very common causative factor. Maceration is a very common contributing factor because when the skin is overhydrated, it's extremely vulnerable. Overhydrated skin loses tensile strength and becomes extremely vulnerable to external mechanical forces. So we'll keep coming back to the role that overhydration plays in superficial skin breakdown. What about superficial shear? We'll look at patients who come in with road rash. What's happened there? The skin literally got dragged across the surface of the road and the skin got removed. So superficial shear, chronic frictional forces, maceration. Those three factors work together to cause most of your superficial skin breakdown. We are going to talk about 4 specific types of partial thickness damage. We're going to talk about friction. We're going to talk about skin tears. We're going to talk about medical adhesive related skin injury, and we're going to talk about moisture associated skin damage. So let's talk first about friction injuries. What is friction? Friction is literally standing force against the skin. So if you've ever refinished a piece of furniture or painted a wall and you've first taken sandpaper and you've taken off the existing finish or the current paint layer, one layer at a time, that's how friction causes damage. It's rubbing against the skin surface, constantly rubbing against the skin surface, taking off skin layers one layer at a time. Patients are at risk for friction damage anytime their skin drags against another surface, against a restraint, against the linen, against the underpad. It's very much like dermabrasion in that you're mechanically abrading skin layers, skin cells one layer at a time. The other thing that happens is when you cause damage to cells, you get an inflammatory response. That inflammatory response in turn makes the skin even more vulnerable. So you have a combination of mechanical removal of skin layers and the negative effects of inflammation. Remember that patients who have very thin, fragile skin are going to be more vulnerable. If you have very healthy skin, you're more resistant to the effects of superficial friction. But if your skin's already at risk, if it's very thin, if it's very fragile, it's much easier to disrupt that layer of skin. Moist skin is also more vulnerable because when the skin cells are overhydrated, they literally swell, and it takes very little external force to cause a disruption in the cell membrane. So your elderly patients, your infants, your patients who have macerated skin, all of those individuals, much higher risk for friction damage. There's a difference in acute friction injuries and chronic friction injuries. So acute friction injuries look very much like this, where you're literally just missing areas of the skin. You can see that this skin is macerated, so this person was very vulnerable, and that in cleaning that patient up or in moving the patient around, the skin was removed. Here you've got mechanical disruption from superficial shear. This is your classic road rash, when someone falls or is in a motor vehicle accident and loses skin. On the top, you see a more chronic friction injury where it's like rubbing against the heel, rubbing against the heel, rubbing against the heel. And finally, you get disruption between the epidermis and the dermis. So you get blister formation. When that blister ruptures, you have exposure of the basement layer of the epidermis or of the dermis. And finally, this is repetitive friction injury over time. Those of you who work with patients in home health or in long-term care might see this kind of picture in patients who are sitting up a lot. Some nurses call this recliner butt syndrome, where the patient's sitting and shifting and sliding and shifting. And what happens is they get a combination of two things. You'll have little patchy areas of skin loss, but you'll also see areas where the skin has become more thickened. That's officially known as lichenification. But you can just say skin thickening. That thickening of the skin is a protective mechanism. So if you ever see areas of skin thickening interspersed with areas of partial thickness skin loss, that is probably caused by chronic friction. But again, you go back to all of the characteristics of a partial thickness wound. Very limited depth, no necrotic tissue, no tunneling, no undermining. And it's going to occur in an area that is exposed to chronic repetitive friction, rubbing, scrubbing. How do we prevent friction injury? Obviously, we want to be very gentle in our skin care. We want to make sure that we lift patients, we don't drag them. We want to keep the skin itself very healthy by routinely using moisturizers that replace skin oils, that replace the ceramides in the skin so that the skin is more resistant. But the most important thing is, can we reduce that repetitive friction, that repetitive force? How can we do that? So sometimes we can reduce frictional forces against the buttocks, against the trunk area, by placing the patient on a low friction, low shear surface, or by using low friction linens. We can protect the heels by putting the patient in a heel elevation device. And I want to differentiate between a heel elevation device, which gets the heel off the bed, and a heel protector. A heel protector is a foam or a cushioned, quilted device that fits around the heel but does not get the heel off the bed. It's designed to help reduce friction and shear, but it does not prevent pressure damage, and it gives the caregiver the illusion that that heel is effectively protected, when in fact that heel is still being subjected to pressure and to some degree of shear. So if you're setting up protocols for your agency, you would like to eliminate use of heel protectors. You would like to make use of heel elevation devices routine across the board. What about protective dressings? Yes, they can be very effective. So you think about how frequently the sacrococcygeal area is exposed to both friction, shear, and moisture. And many of you work in settings where you have incorporated routine use of silicone adhesive or gentle adhesive foam dressings to the sacrococcygeal area as part of your pressure ulcer prevention protocol. That makes really good sense. So can I use a gentle adhesive foam dressing to the sacrococcygeal area to reduce the negative effects of moisture and friction? Yes. That, in conjunction with a low shear, low friction support surface, and with lifting instead of dragging, can go a long way toward minimizing partial thickness skin loss over the sacrococcygeal area. What about over the heels? What about over the elbows? Yes, dressings can help protect any area that's exposed to chronic frictional forces, to chronic rubbing and scrubbing. So sometimes we'll take something like Opsite or Tegaderm and we'll put it over the elbows. It's like giving that patient an extra layer of skin over the elbows if they're using their elbows a lot to reposition themselves in bed. Ideally, for the heel, we're using heel elevation devices to get the heel off the bed. Could we also use a transparent adhesive dressing like Opsite or Tegaderm to further protect against repetitive friction? Yes. So protective dressings can be helpful to any area that's exposed to repetitive rubbing force. How do we manage these wounds when they occur? The principles are simple, but hard to operationalize. So first of all, we want to interrupt the cycle of injury by stopping that rubbing, stopping the scrubbing. So we want to make sure that everybody's lifting, not dragging. We want to keep people on low shear, low friction surfaces as much as possible, and we want to minimize skin layers between the skin, or minimize linen layers between the skin and the surface. If I have a low friction, low shear surface, but then I've got 4 layers of linens and 2 layers of underpads, my skin's not very well protected. So really teaching staff about the importance of minimizing layers between the skin and the resting surface. So first of all, interrupt the cycle of injury. Secondly, come up with a dressing or a topical therapy protocol that keeps the surface moist and protected and manages any exudate. Sounds easy, but sometimes that's very hard to do. Usually you get into a situation where you are either going to use a dressing or you are going to use an ointment. Dressings in general are better. So if that wound is in an area where you can get a dressing to adhere, that's a better choice. Why? Because it provides much better protection against mechanical trauma. So if I can get a dressing to that lesion on the buttock or in the sacrococcygeal area, not only do I keep the surface moist and protected, but I'm minimizing frictional forces against that area. So I'd much rather try to get a dressing to adhere to each of these lesions. I'd much rather use a gentle adhesive foam dressing or a hydrocolloid dressing, anything that will protect that area from repetitive trauma. That's a better choice than an ointment if I can make it work. So I'm going to try really hard to make that work. If I can't make that work, then I will use an ointment and reiterate with the staff the importance of keeping the area covered with the ointment, lifting the patient, not dragging the patient, all of those things to try to interrupt the cycle of injury in addition to keeping the surface moist and protected. Okay, next we're going to talk about skin tears. I don't care where you've worked, I know you've had patients with skin tears, and you know what they are. You've had traumatic separation either between the epidermis and dermis or between the dermis and the subcute. Now, most of the time, skin tears are partial thickness, which means you've got separation between the epidermal layer and the underlying dermal layer. Very common wounds in the infant population and in the elderly. Why? because of differences in the anatomy and physiology of the skin during those periods of time. In the infant population, that interlocking configuration between the epidermis and dermis has not yet developed, or is incomplete, which means the layers kind of just sit on top of each other, and it's very easy to separate the epidermis from the dermis. In the elderly, that interlocking configuration has been lost, so you end up with exactly the same thing. One layer just sitting on top of the other, very easy to cause disruption. Also much more common in patients with thin skin and patients who are being managed by others who are handling them a lot, because that increases the risk that you'll get skin tears. We'll come back to risk factors. There is a relatively new classification system developed by ISTAB, International Skin Tear Advisory Panel. Very simple and very logical, easy to follow classification system. So I would suggest that you start to incorporate this when you write protocols for skin tear management. So type 1 means there is no skin loss. The skin edges can be reapproximated. Any flap completely covers the area of injury. So if you look at the top, you can see that those skin edges can be reapproximated, and there's no actual open wound. That's type 1. Type 2 means you have partial skin loss. So even though this flap and this flap almost completely covers the wound, it does not completely cover the wound. That would be considered a type 2, partial skin loss. So you're going to have to manage that as an open wound. And type 3 means you have total flap loss, so you're going to have a lot more exudate, and you're going to have to take that into consideration when you select your dressings. So type 1, no skin loss, no open wound. Type 2, partial skin flap loss, so you do have an open wound, but usually it's limited with limited amounts of exudate. In type 3, total flap loss, a much larger wound, much higher volume of exudate. Okay, I told you we'd come back to risk factors. So we've already talked about extremes of age being a major risk factor. Patients who are critically ill or chronically ill are higher risk. Most of them have protein depletion and have very thin skin. When your skin is very thin, it's much easier to disrupt the skin layers. We talked about the fact that patients who are dependent on others for daily care, who are handling them, so when I come in to turn you over, to sit you up, to get you up, into the wheelchair, out of the wheelchair, multiple opportunities for me to inadvertently pull on your skin and cause a skin tear. Purpuric lesions. If you have those purple areas on the skin, it tells you, number 1, that the skin's very fragile, number 2, that the blood vessels are very fragile. That patient's higher risk to develop a skin tear. What actually causes them? Mechanical trauma exerted at the surface of the skin. So sometimes it's bumping into the wheelchair, bumping their leg against the wheelchair, their foot against the wheelchair. I've seen that many times. I know you have too. Bumping into objects. Maybe they bumped against the bed rail, or they were out of bed and they bumped into the bedside table. Sometimes it's inappropriate technique and tape removal and dressing removal that causes literally disruption of the skin. Sometimes it's care techniques that have to be done, like venipuncture. And so I have to stabilize the vein to do the venipuncture, and in so doing, I pull the epidermis against the dermis. So if you're an infant or you're elderly, if you're critically ill, chronically ill, very high risk. And sometimes it's not totally preventable. So let's talk about what we can do to prevent skin tears. Obviously, when we have these little infants and we have elderly patients, we have patients who are critically ill or chronically ill, the last thing we want to do is induce more skin trauma. And the reality is that we've learned a lot about what causes skin tears, which translates into we know so much more about how to prevent them. So most skin tears can be prevented. Here's how. First of all, really think about what tape to use and how to use it. If you are securing a non-essential device, like a dressing, then you want to use silicone tape or paper tape. If you are securing an essential device, like an endotracheal tube or a critical IV access line, then you don't want to use gentle tape. You have to use a more aggressive tape because you have to be sure that that line, that device remains in place. But in that case, you can put down a base before you apply the tape. Minimally, you should be using a liquid barrier film, like your spray-on or paint-on liquid films that we sometimes call sealants. Most of the time, you should be putting down either a silicone adhesive foam dressing or a hydrocolloid dressing, and then taping the device to the foam or to the hydrocolloid so that you have the device effectively secured, but you have the skin protected. So think about, am I using the right tape? Am I using the right technique? Have I incorporated the appropriate level of skin protection? Secondly, you want to be sure that your routine skincare program involves use of a moisturizer to replace lost lipids, because studies have shown that if you keep the skin soft and supple, it's much more resistant to superficial damage, including skin tears. Pad your side rails. If you have a very vulnerable patient, apply a sleeve to protect the patient's arms, socks to protect their legs. Here's a commercial sleeve, but what if you don't have a commercial sleeve? There's a lot of ways to protect a patient's arms. If they're in home care, you can literally take knee socks and cut out the toes and give them a little thumb hole and use the knee socks to protect the arms. And then they have a match set, so you can make them colorful. If you don't have knee socks, you don't have a commercial sleeve, do something as simple as wrapping the arm in a soft roll gauze, something like Conform or Cling. And what does that do? First of all, it gives them a layer of protection, and it also alerts everyone, handle this patient with care. And of course, that's a key element. Just thinking, this patient's very high risk. Let me be very gentle in pulling them over. Let me use that lift sheet or that underpad instead of grabbing them with my hands. Let me use the palms of my hands when I'm pulling them up and try to avoid my finger pads that could grab the skin and tear it. So gentle skin care, gentle handling. How about managing skin tears? Well, if it's type 1, you don't really have skin loss, but you have a very vulnerable area. So here you want to, of course, cleanse the wound. You want to roll that flap back into place, approximate the edges. You can secure the approximated edges with little steri strips to hold the skin in place. Now, if you have a flap, you need to realize the flap is not going to stick back down. It's not going to act like a skin graft. But what it will do is it will protect the underlying wound bed while it epithelializes. So what it becomes is the world's most effective dressing because it's skin. Do you want to put anything on top of that? I would say yes. I would say yes, you want to cover it with a gentle adhesive foam or with a non-adherent layer and secure it with wrap gauze. Because that area is extremely vulnerable, you want to protect it. If you have type 2 or 3, then you have variable areas of skin loss. So of course you're going to clean the area. You're going to select a dressing and you're going to think about these things. You need to manage exudate. You need to keep the surface moist, and you need to prevent trauma with removal. So exudate control, moist wound surface, atraumatic removal. So think about dressings that have been used a lot in the past. What about a transparent adhesive like Tegaderm or Oxide? Is that a good choice? Well, let's go through the criteria. Will it maintain a moist surface? Yes. Will it manufacturate? No. Will it provide a traumatic removal? No. Not a good choice. We should not be using transparent adhesive dressings. What about hydrocolloid dressings? Will it maintain a moist surface? Yes. Will it manufacturate? Very little. Very, very little. So most of the time the answer would be no. Will it provide a traumatic removal? No. Is it a good choice? No. What about a silicone or gentle adhesive foam? Will it maintain a moist surface? Yes. Will it manufacturate? Yes. Will it provide a traumatic removal? Yes. That would be a great choice. What about a non-adherent contact layer, which might be Vaseline gauze, it might be Adaptic, it might be Zeroform gauze, it might be one of your silicone adhesive contact layers that you put over the wound, and then you put gauze and you secure with wrap gauze. Would that combination maintain a moist surface? Yes. Would it provide for exudate control? Yes, because of the secondary gauze dressing. Would it provide a traumatic removal? Yes, your base layer is non-adhesive. So that would be another very appropriate choice. Now, if you had to decide between teaching your staff to routinely use a gentle adhesive foam dressing and teaching your staff to routinely use a non-adherent contact layer dressing plus gauze and wrap gauze, here's some things to think about. If you use a gentle adhesive foam dressing, you can leave that in place 3 to 5 days. If you use a non-adherent contact layer like Adaptic, Vaseline gauze, etc., most of the time that dressing needs to be changed every day. So from a staff nurse perspective, and probably from a cost perspective, the gentle adhesive foam might be a better choice. Either one would be appropriate from a physiologic perspective, but from a daily use implementation perspective, maybe your gentle adhesive foam would be your preferred method of management. So we've talked about friction injuries, we've talked about skin tears. Now we're going to talk about another very common type of wound, and that's medical adhesive related skin injury, also known as MARSI. A relatively new term, but one you want to start using and one you certainly want to recognize when it's used in a presentation or an article. What is this? It is literally damage to the skin related to the use of medical adhesive products. If you see redness or other indicators of skin damage that persists for more than 30 minutes after removal of the adhesive product, that is by definition medical adhesive related skin injury. There are 3 specific types of medical adhesive related skin injury. First of all, sometimes we literally tear the skin off. That's also known as skin stripping or mechanical disruption of the skin. Sometimes you get a contact dermatitis, a reaction of the skin. And sometimes you get maceration. So we're going to talk about each of those in a little bit more detail. What are the risk factors for medical adhesive related skin injury? Interestingly, and it makes sense, pretty much the same as we talked about under skin tears. So extremes of age, because what do we know about skin in the neonatal population and the infant population and skin in the elderly? Very thin, very fragile, much more vulnerable. MARSI is much more common in intervention intense care areas like the emergency department or the intensive care unit or the operating room or PACU. Because think about how many adhesive products are used in those areas. Think about how many lines are placed and secured with adhesive products. So many patients in intensive care have multiple lines, multiple dressings, leads, many things that can cause medical adhesive related skin injury. Anyone who at baseline has fragile skin, so you're a malnourished patient, you're a patient with an underlying dermatologic condition, you're a patient who is on steroids, all of those patients are higher risk. And patients who are getting chemo or radiation, for obvious reasons, chemo and radiation both interfere with the reproduction of skin cells and make the skin much thinner and much more vulnerable at baseline. Can we prevent MARSI? And the answer is yes, many times we can. In the past, our attitude has been somewhat cavalier, like, well, we have to take things down, and sometimes you're going to get injury. But the more we've learned about the anatomy and physiology of the skin, and the more we've learned about the different types of tape available to us, the different types of adhesives, the more we realize that the vast majority of these wounds can be prevented and should be prevented. Obviously, we're going to avoid products to which the patient has known sensitivity. So if the patient comes in the door telling you, I'm allergic to Tegaderm, you're not going to use it. If they tell you I'm allergic to silk tape, you're not going to use it. Many times, we can secure the device without using an adhesive product. So if the device is on an extremity, we should consider use of rat gauze to secure the device instead of use of adhesive. You're going to see that a lot of non-adhesive securement options are being introduced to secure critical lines, like ET tubes. Or if they require adhesive, you're going to see skin-friendly options, and we're going to come back to that in just a minute. The third thing you should think about is selection of your tape. And you want to think first, is this an essential device? Is it critical for me to get a really good seal and to maintain a good seal? If this device comes loose, is it going to have negative effects on this patient? If it is a non-essential device, and we've used the example of dressings. Most dressings are non-essential. Yes, they need to be there and they're going to promote wound healing, but nothing terrible is going to happen if one edge lifts. So if I'm using adhesive for a non-essential device, like we just said, you can use a gentle adhesive, a silicone tape, a paper tape. But if it's an essential device, I need to use a silk or a cloth tape. However, as we've already said, I can put down something to protect the skin. So I can either paint my skin with a liquid protective barrier, or I can put down something like a hydrocolloid or a silicone adhesive foam. One thing that we should know, paper tape is a very gentle tape, but you have to know what you're doing when you apply paper tape. It's an acrylate adhesive, and acrylate adhesives are pressure sensitive. So when you apply paper tape, you know how a lot of times you'll put tape all the way around the edges and you can see even at baseline that tape is not sticking? And it's because we need to use pressure to get that acrylate adhesive to bond to the skin. So gentle pressure with paper tape. The other thing you should know about acrylate adhesives, paper tape, is that the bond becomes tighter over time. So that paper tape that looked like it was going to lift when you put it on Monday can be very difficult to remove on Wednesday because now you've got full bonding of the acrylate to the skin. So paper tape is skin friendly, but if you want to get the best results, use pressure when you apply it. We want to always apply our tapes to clean, dry skin. We don't want to trap moisture underneath. We want to apply without tension so that we don't get tape blisters. And probably the one thing that you want to teach everyone is the correct technique for removal. 2 words, low and slow. So low refers to the angle. So we don't want to pull up on the tape. We want to turn the tape back on itself and pull it parallel to the skin. We want to remove it slowly. We want to put pressure on the skin so that we're doing push-pull, push-pull, push-pull. Pushing down on the skin, pulling up on the tape. So, selecting our tapes correctly, applying it to clean, dry skin without tension, providing appropriate protection underneath the tape, a liquid barrier film, a solid hydrocolloid dressing, and teaching people correct removal can go a long way toward preventing medical adhesive-related skin injuries. The last type we're going to consider under top-down partial thickness skin damage is moisture-associated skin damage, another relatively new term. Actually, it was our friends across the Atlantic, the European Pressure Ulcer Advisory Panel, that first started looking at separating out wounds caused by pressure and wounds caused by moisture, because they started realizing that a lot of patients who were at risk for pressure injury were also at risk for moisture-related skin damage, and that many times wounds were being classified as pressure injuries when in fact they were caused by moisture. So they actually initiated the early strategies to separate out moisture-associated damage from pressure injuries, to talk about what are the characteristics of each, how do we classify wounds correctly. So now you'll see the term moisture-associated skin damage throughout the literature on skin and wound care as a term you want to use, and you want to use it correctly. So what does it mean, moisture-associated skin damage? What happens here is that when the skin becomes overhydrated, it becomes extremely vulnerable. So you get skin that's overhydrated, it's macerated, it's waterlogged, and then you can get actual skin loss if that overhydrated skin is exposed to friction, is exposed to enzymes, is exposed to irritants, is exposed to pathogens. Because overhydrated skin has very low tensile strength. Also, when the skin is overhydrated, you've lost a lot of the barrier function, and that means that it's much easier for irritants to penetrate, for enzymes to penetrate, for pathogens to penetrate. So you want to think of moisture as kind of the setup guy. It makes the skin much more vulnerable to every type of damage. And then the actual damage is typically caused either by mechanical forces like friction, pathogens, or irritants and enzymes. There are 4 specific types of moisture-associated skin damage that are commonly referred to in the literature. I'm sure that this list is not exclusive, but these are the 4 you need to know at this point. Incontinence-associated dermatitis, abbreviated IAD. Intertriginous dermatitis, abbreviated ITD. Peri-wound MASD, and peristomal MASD. So let's talk about each of those. Incontinence-associated dermatitis is obviously moisture-associated skin damage that's caused by either prolonged or repetitive exposure to stool and or urine. Liquid stool seems to be the most damaging because it has high levels of enzymes. So look at your patients with C. diff. They're going to have a very high incidence of IAD. Solid stool less damaging, urine less damaging, but chronic exposure to urine can also cause damage. Exposure to a combination of urine and stool can also cause damage. So it may be liquid stool alone, it may be solid stool mixed with urine, or it may be ongoing exposure to urine. Again, you've got 2 things going on. You've got overhydration of the skin from exposure to the urine or to the liquid components of the diarrheal stool. That sets the skin up. Then you get skin loss either because there was penetration by irritants and enzymes, which we see a lot in the patient with C. diff. Sometimes you'll see candidiasis because of penetration by fungal organisms. Many times you'll see patchy areas of skin loss caused by cleaning the patient up repetitively and taking off little layers of skin, little areas of skin. Because the skin is very fragile, it's very moist, I've had to clean you up 6 times this shift. Every time I clean you up, even though I'm trying to be gentle, I'm taking off some skin cells, and by the end of my shift, your skin's gone from inflamed to denuded. So multiple things going on with incontinence-associated dermatitis. Risk factors, like we said, the major one, fecal incontinence, especially liquid stool. Combination of urinary and fecal incontinence because they act together to cause higher levels of skin damage. Chronic exposure to urine alters the pH of the skin. That activates fecal enzymes that cause more skin damage. So combination of urine and stool or liquid stool, very damaging. Prolonged exposure to urine can also cause damage. Obviously, a patient who has fragile skin at baseline, so your critically ill patient, your elderly patient, your malnourished patient, your patient who's also on radiation or chemo, your patient who's also on steroids, anything that makes the skin more vulnerable at baseline makes them higher risk for MASD and at an earlier point. You all know how incontinence-associated dermatitis presents. So we start out, we have intact skin. We start having episodes of diarrhea, and what happens? Now the skin is inflamed and tender, so it might look red, very tender to touch. Think about times you've had gastroenteritis. I know you couldn't see your perianal skin, but you could feel it. And it became progressively more tender, right? So you start out doing routine wiping with the focus of getting clean. And as it progresses, you become more and more concerned with the level of pain involved in cleaning yourself up. As you go from wiping to patting, from not worrying about what kind of tissue paper you have to looking for the softest that you've got, to going to a moist wipe, to thinking I'll just hop in the shower. Okay, so think about that as we see the progression to inflamed skin, the patient's feeling the progression to very tender skin. Then you can progress to skin loss, to patchy areas of skin loss, associated with cleansing, associated with moving around in bed that takes off areas of that very thin, very fragile skin. You may get candidiasis. You might see a yeast rash because of penetration by the fungal organisms. But here's a very important consideration. All of these findings occur in areas exposed to stool and or urine. So that redness, those patchy areas of skin loss, the fungal infection, all occur in the perianal area, perineal area, inner thighs, buttocks. We want to prevent IAD. It's painful, it's a risk factor for more severe damage like pressure injuries, and it can be associated with infectious complications. Most of the time we can prevent IAD if we incorporate all of these measures right away. First of all, can that patient get up and go to the bathroom? Can we manage them with toileting? Well, then we definitely want to manage them with toileting. In reality, especially in acute care and long-term acute care, most of our patients have limited mobility. Many of our patients are bedbound. Many of them are sedated. So they may not be aware, they may be incontinent in addition to having diarrhea. In that case, we should think about containment systems. So is this patient a candidate for an internal bowel management system? If so, maybe I should initiate one of those to limit exposure of the perianal perineal skin to that liquid stool. Is this patient a candidate for an external catheter? Then maybe I should initiate that to prevent prolonged exposure to urine. So first of all, we try to minimize the exposure to stool and urine. Secondly, and I'm going to actually skip in order, we want to use absorptive products appropriately. So some of our patients absolutely will require absorptive products. They will require briefs and underpads because they're incontinent and they're not a candidate for an internal bowel management system, or they have some leakage around the bowel management system. We want to use absorptive products correctly. So what's the big deal with absorptive products? Why is everybody so anti-diapers all of a sudden? Well, think about what happens when you close an adult brief around the patient. Good things happen and bad things happen. On the good side, now you're containing the urine and the stool. You're protecting the patient's dignity if that patient's incontinent. So those are positives. But on the negative side, when you close that brief up around the patient, most of those briefs have a waterproof outer layer, a plastic film. So as soon as you close the brief around the patient, you create an occlusive environment that very much limits the transfer of heat and moisture. As soon as you close it up, the perineal skin begins to sweat. When you have hot, wet skin, you have extremely vulnerable skin. Remember, cool, dry skin is healthy, happy skin. Hot, wet skin is vulnerable. So we want to minimize occlusion. Now, there's a couple of things we can do. We can either use products that have at least a semi-occlusive outer layer, or we can leave the products open while the patient's in bed so that the urine, the stool goes onto the absorptive surface, but it's not closed up around the patient. And we can limit use of closed briefs to periods of time when the patient's out of bed off the unit. The other thing that matters a lot, go back to diaper technology. Look how our diapers have changed. Diapers have changed tremendously. And with the advances in diaper technology, there's been a marked reduction in diaper dermatitis. So now infant diapers all have polymers that wick urine, wick the liquid components of stool away from the skin and help to keep the skin drier and healthier. You want the same thing for your patients. You want absorptive products with polymer technology to wick the liquid away and to keep the skin drier and more resistant. So fight for polymer-based absorptive products. Educate your staff that when the patient's in bed, leave the device open if at all possible, and limit periods of time when the device is closed around the patient to periods of time when they're out of bed. Now, let's go back to cleansing and protecting. Every time that patient has an incontinent episode, we're going to clean them up. But we want to clean them up correctly, which means two things. First of all, I should not be using soap and water. I should either be using impregnated wipes, just like, go back to infant care, just like what do we use routinely to clean babies up? Impregnated wipes. And what are those wipes impregnated with? Surfactants, skin oils, okay? Skin-friendly ingredients. We should be doing the same thing for our adult patients. We should be using impregnated wipes that have surfactants, possibly some antimicrobials, and definitely skin lipids to keep the skin healthy. If we don't have impregnated wipes, we can also use soft disposable washcloths with perineal cleansing foams or perineal cleansing solution. But whatever we're using should be no rinse. It should have moisturizers incorporated. It should be pH balanced. And the delivery system should provide for atraumatic cleansing. So either soft disposable cloths or impregnated wipes. If you're not using impregnated wipes, make sure that your perineal cleanser is pH balanced no rinse. Okay, so gentle cleansing after each incontinent episode. And then what else? We need to use moisture barrier products, and those moisture barrier products should incorporate moisturizers. What do moisturizers do? Remember that you've got both skin cells and you've got skin mortar. And what's the mortar? Your skin oils. Skin oils or your skin lipids. Fills the gaps between the skin cells to maintain that barrier. Think about the time, every time we clean a patient up, we tend to remove some of those skin oils, those skin lipids. We tend to create gaps in the barrier. So very important that every time after we clean the patient, then we restore skin oils. Now your impregnated wipes do that automatically because they incorporate surfactants for cleansing and skin oils for maintaining the barrier function. Many of your moisture barrier products also incorporate moisturizers that replace lost lipids. You just got to make sure, in looking at the products that you use in your agency, that you're providing atraumatic cleansing and that you're routinely replacing skin lipids, either through use of an impregnated wipe or through use of a moisture barrier combination that replaces moisturizers in addition to providing a barrier. Okay, let's talk about barriers. When you talk about incontinence-associated dermatitis, the sources of moisture are urine and stool. So those are external moisture sources. We always want to protect the skin by applying something that acts like an umbrella or a raincoat that prevents contact between the urine and stool and the skin. So there's a lot of ointments out there. Most of them are either dimethicone-based, petrolatum-based, zinc oxide-based, or a combination. And we also have the option to use liquid barrier films, our alcohol-free spray-on or wipe-on films. So we're going to talk about these briefly. If you're using a dimethicone-based product, so a lot of your impregnated wipes incorporate dimethicone. What are the good and bad things about dimethicone? Well, one very good thing is that it's non-occlusive and non-greasy. So if your patient's diaphoretic, it allows that skin to breathe. Okay, it allows moisture transfer. Also, it's very easy to apply, so you don't get any trauma with application or removal. And it gives you good protection against urine and against solid stool. But it doesn't usually give you enough protection against liquid stool unless it's combined with zinc oxide. What about petrolatum? Plain old Vaseline-based products. Well, again, easy to apply and easy to remove. Good protection against urine and formed stool. Actually acts as a moisturizer in that it donates lipids to fill gaps between the skin cells. Dimethicone does that as well. One thing you have to teach staff if you're using a petrolatum-based product, you know how people think if a little bit's good, a whole lot is better, so you'll come and they'll have this thick layer of ointment. That is absolutely not true with petrolatum. They did a study that showed when we apply a thick layer of petrolatum, what happens is the petrolatum transfers to the underpad or the brief. So now you have waterproofed the underpad, waterproofed the brief, but the skin is no longer protected. So with petrolatum, a thin layer is ever so much better than a thick layer. The last one is zinc oxide. So I always say, what's the good thing about zinc oxide? And everybody says in return, it doesn't come off. It's hard to get it off. Okay, it provides high-level protection because once you put it on, it tends to stay on. So what's the good thing about zinc oxide? It doesn't come off easily, so it gives you high-level protection. What's the bad thing about zinc oxide? It doesn't come off easily, so people frequently cause trauma in trying to remove it. So the thing about zinc oxide is that out of all the barrier products on the market, it gives you the best protection against liquid stool and the best protection for damaged skin. The downside to zinc oxide is that staff can inadvertently damage the skin if they don't know how to remove it properly. So we're going to talk about some things they can do to remove it more easily. What do you want them to know? They should use a perineal cleanser, either your perineal cleansing foam, perineal cleansing solution, impregnated wipe. The surfactants in those products will help to gently remove the zinc oxide. You could also use mineral oil, but your perineal cleansing solutions and wipes are the best way to remove zinc oxide. What else could you do? Well, on the market there are zinc oxide petrolatum combinations, and now you get the benefits of both petrolatum and zinc oxide. So it's much easier to remove, much easier to apply thanks to the petrolatum, but also gives you higher level resistance thanks to the zinc oxide. You could apply the zinc oxide and then you could fan fold strips of Vaseline gauze or visco paste or whatever to protect the zinc oxide, so that when you take off the strips, most of the zinc oxide comes with it. You have less to remove. There's a number of different techniques that you can use to make removal easier. Critical to come up with some simple strategies that you reinforce over and over and over to your staff. Maybe you want to change your stock item so that it's a combination of zinc oxide and petrolatum. And then you want to teach your staff a relatively thin layer, not so much. Always use your impregnated cleansing wipe or your perineal cleansing agent to remove. You can also use your liquid barrier films, and that's particularly effective if you have either urinary incontinence or you have incontinence of soft to formed stool. So very good protection against urine and against relatively formed stool. One advantage, you just spray it on and it's transparent, so it's very easy to apply. You don't remove it and you can easily monitor skin status. You want to be sure that your formula is alcohol free. And you also want to make sure that the liquid barrier film you're using is compatible with your perineal cleansing agent. You want to make sure that the perineal cleansing agent doesn't break down the alcohol-free barrier film. So you need to talk to your vendor reps and say, can I use these two products together? How do we treat IAD? It's helpful to divide it into mild, severe, and candidiasis. So if you have mild IAD, it's like the guy on top, or woman, probably woman. But anyway, the point is, you've got inflamed skin, but you have no areas of skin loss. So yes, the skin is inflamed, it's red, it's probably tender to the touch, but no areas of skin loss. If you don't have a prevention program in place, you're going to put one in place. If you already have a prevention program in place, you're going to think, what's going on? Because I'm not getting the level of protection I need. Do I need to ramp it up? Do I need to substitute a zinc oxide petrolatum moisture barrier for petrolatum only? What needs to change? So specific things to think about, make sure that people are using containment products appropriately, that they're using absorptive products appropriately. Revisit, do I have the right cleansing product in place? Am I using something that's pH balanced, that is no rinse, that provides a moisturizer? And do I need to change my moisture barrier? Now look at this. This is severe IAD. This is where you have multiple areas of wet, weepy, raw, denuded skin. The patient's in a lot of pain. You go to clean them up. It hurts them. It hurts you. Reassess the need for a containment product. So if this patient has frequent episodes of diarrhea and there's no bowel management system in place, revisit that. Is the patient a candidate? Could you use a bowel management system? At this point, it's probably too late for a perianal pouch because the skin's too wet. If I still have intact skin, yes, I can use a perianal pouch. If the skin's totally denuded, no, it's too late. This is where we typically need to move to a zinc oxide-based moisture barrier. But you will find that many of your zinc oxide products do not adhere well to denuded skin. So what can you do? You go to put the zinc oxide-based product on, and it doesn't even stick. It sticks to the good skin, but it just slides right off the damaged skin. So here's what you can do. You can do your crusting technique as a base. So sprinkle on your ostomy powder, dust off the excess, spray it with an alcohol-free barrier film. Maybe you repeat it again and then apply your zinc oxide. That can be extremely helpful to teach your staff that. The other thing, think about a covered dressing so that after you get your ointment in place, it doesn't transfer to the underpad. So maybe you do your crusting, then you put your ointment, then maybe you do a Tegaderm. I know the Tegaderm won't stick per se, but it will stay in place against the ointment, and now it gives you kind of a cover that keeps it from transferring to the underpad. In home care, sometimes they'll do a layer of zinc oxide and then a square of Glad Wrap Press and Seal to do the same thing, just to create a cover. But in acute care, long-term acute care, typically we'll use something like Tegaderm, Opsite, Biocclusive, whatever we've got. Also, again, consider your combination product, your zinc oxide and your petrolite. What if you have candidiasis? So many times when you have IAD with candidiasis, the skin remains intact, but you've got clear-cut evidence that you have a fungal infection. You've got that maculopapular rash, you've got distinct border lesions. So you know you need an antifungal. So you're going to go back and make sure you're managing your incontinence correctly. You're going to make sure that you're minimizing occlusion because you don't want hot, wet skin. That's ideal for fungal growth. You want cool, dry skin. And then you want to make sure that your moisture barrier incorporates an antifungal. And there are a number of commercial moisture barrier ointments on the market that have an antifungal, typically miconazole. What else could you do? What if you don't have a moisture barrier with miconazole? Well, then you can start out crusting with an antifungal powder, miconazole or nystatin, and then put your moisture barrier on. Okay, so we've said there are 4 distinct types of moisture-associated skin damage. We've talked about incontinence-associated dermatitis, where it's all about protecting the skin from urine and stool. Now we're going to talk about intertriginous dermatitis, or ITD, which is very different. And these lesions are very, very commonly mistaken for pressure injuries. So what is intertriginous dermatitis? It's skin damage caused by trapped moisture between body folds. So you trap moisture between body folds. This is seen a lot in your bariatric population. It's common in your infants because they have a lot of body folds. Any patient with a body fold is at risk. Bariatric patients, where do you see ITD? Underneath the pannus, underneath the breast, okay? Underneath the arms, in the groin folds, infants in neck folds. Any place you have skin folds, this can occur. What happens? The skin becomes macerated and vulnerable. And then there's 2 sources of damage. One is the 2 sides of the skin folds rubbing against each other, so you can get mirror image lesions where this side rubbed against this side and create a superficial skin loss. Or you can get a crack at the base of the skin fold. Sometimes those cracks occur spontaneously. Sometimes you go to clean the patient up or to assess the skin and you're lifting the skin folds, you're separating the skin folds, and just that slight tension can cause the skin to crack. You're like, oops, I didn't do that, did I? easy to happen. So you can see this in the gluteal cleft as well as everywhere else that we've talked about. So skin loss, either friction or a crack in the overhydrated skin. Also remember that this is a very moist area. Fungus loves moisture, so it's very common to see a coexisting fungal infection. Sometimes you'll get a coexisting bacterial infection, so you just have to be aware of that. So how do they present? Either a linear break, you see a linear break here, linear break here. You see that the surrounding skin is very macerated. Here you see a coexisting candidiasis in addition to kissing lesions, okay? Superficial lesions on either side of the skin fold. Again, our goal is always prevention, and a lot of times we can prevent ITD. If you can, you absolutely want to. These lesions are very difficult to heal, especially those linear breaks at the base of skin folds. People classify them as pressure injuries. They're not. They're moisture wounds, ITD, not pressure wounds. Very, very difficult to manage. So you'd much rather prevent. Well, how are you going to do that? Go back to the two problems: moisture accumulation and friction between opposing body folds. So let's deal with moisture first. If we could whip the moisture away, then we wouldn't have overhydrated skin to begin with. And secondly, if we could separate the body folds, we wouldn't get those frictional forces. And you can do both of those with one product. So there's a commercial product on the market, Intradry by Coloplast. And you see that here. So you can see that you tuck it into the body fold, and you have to leave about 4 inches of the wrap exposed, or of the fabric exposed to the air, because the goal is to wick moisture from the base of the fold out, and then it evaporates. Wick, evaporate, wick, evaporate. It's impregnated with silver, so it also kills organisms, and it separates the two body folds. So if you have that, that's perfect. You just have to teach people how to use it. Last week I found it in a wound. So clearly somebody didn't understand how to use it. So I've got to go back and do some more education. So you've got to teach people how to use it. You always have to have several inches exposed to the air. So moisture is wicked and evaporated, wicked and evaporated. You can use one piece for 7 days. You can even wash it and reuse it. After you wash it, you tend to lose the effects of the silver, but you retain wicking effects. So you want people to know how to use it correctly. What if they don't have that? What if you don't have that? Could you use a peri pad, an ABD pad? Nurses use towels. In home care, you can use athletic socks, anything that will separate, absorb, wick. If you have a patient who is also incontinent, so they're both diaphoretic and incontinent, and you need to use a moisture barrier, use a moisture barrier with dimethicone so you're not trapping moisture. Because remember, with ITD, the moisture source is internal, is coming from the skin out. With IAD, the moisture source is external, urine and stool. So petrolatum works with IAD because you're putting a barrier between the skin and the moisture. Zinc oxide works with IAD. But with ITD, the moisture is coming from inside out. So what you want to do is use something that lets moisture evaporate. So if you have to use a moisture barrier, use one that's dimethicone based. How about management? What do people want to do? They want to put ointments because these are linear cracks that are very difficult to dress. But if you add an ointment, does it address either of the underlying factors, moisture and friction? Not very well. You trap more moisture. I've come in and found people swimming in moisture barrier ointment, so it's trapping moisture, and you've got skin surfaces rubbing back and forth. So if at all possible, You would like to manage these wounds with dressings. What are your goals? Keep a moist surface, manage excess moisture, separate body folds, right? So if I can use a gentle adhesive foam, I will. If I can use even a hydrocolloid, that would be better than an ointment. So you think about, can I use a soft, gentle adhesive foam? Can I use a hydrocolloid? That would be better if I can use that than just using an ointment. If I can't do that, then maybe I want to crust first and then do a thin layer of the moisture barrier ointment and then use a soft folded gauze to separate the body folds. Always go back to what you're trying to do. Also be very alert to indicators that you have a coexisting fungal infection, because in that case you have to use an antifungal. Be aware that they can get bacterial infections, so if they're not responding to what you're doing, culture. Just a couple of more things and then we're going to take a break before we go on to pressure. So peri-wound, moisture-associated skin damage. Not surprising that peri-wound tissue is at risk for moisture-associated skin damage because most of our wounds are highly exudated. And if you expose the intact skin to wound exudate, you're going to get maceration. If you have a chronic wound, you're very likely to get inflammation because chronic wound fluid has very high concentrations of inflammatory mediators. So you end up with skin that's wet, possibly inflamed, much more vulnerable to any kind of mechanical trauma like adhesive removal. So we want to routinely be protecting the peri-wound skin. And when we get into wound management, we'll come back to this again. How does peri-wound MASD present? Well, you already know this. You take off a dressing, you see skin around the wound that looks waterlogged, it looks overhydrated. It may be erythematous, then you can see patchy areas of skin loss. Sometimes you have candidiasis. So here's a neuropathic ulcer on a diabetic patient. We'll talk more about this in a later class. And what you have is soft macerated callus all the way around the wound edge. Tells you wound fluid is sitting on that surrounding skin. Here we have venous ulcers, and what do you see all the way around the ulcer? Erythema, maceration. So how do we prevent it? Two things. You base dressing change selection and dressing, back up. You base dressing selection and dressing change frequency on the volume of exudate. So if you have a very wet wound, you want a highly absorptive dressing and you're going to change it more often than if you had a wound with minimal exudate. Also, it should become routine practice to protect the peri-wound skin with some kind of moisture barrier. If it's an extremity wound, you could use a moisture barrier ointment because you can secure the dressing with a wrap gauze. If it's a trunk wound, you're much better off using an alcohol-free liquid barrier film because most of the time trunk wounds are going to be managed with adhesive dressings. So routine use of a moisture barrier. If you take off a dressing and you already have peri-wound MASD, you go right back. Okay, do I need to change the type of dressing? Do I need something that's more absorptive? Do I need to change the dressing more frequently? How have I been protecting the peri-wound skin? Should I change that? Is the peri-wound skin wet and denuded? Then I might need to do some crusting. And finally, peristomal MASD, and obviously we'll discuss this a lot more when we get to ostomy care. But here you've got skin damage due to exposure of the peristomal skin to urine or to stool. Now the primary moisture source obviously is again external, urine, stool coming out of the stomach. But if the patient's very diaphoretic, if they go to the gym a lot and work out a lot, if they're working outside as a construction worker and it's hot and they're sweating a lot, then internal sources of moisture can contribute and can make things worse. What are the clinical characteristics? Take off the pouch and what do you see? You see maceration of the peristomal skin. You might see erythema of the peristomal skin. You might see patchy areas of skin loss like you see here. And the area may be very, very tender. The patient might report itching, burning. Sometimes you'll see overgrowth of the skin from repetitive, prolonged exposure to moisture. But it will be obvious that something's wrong with the peristomal skin and that it's caused by exposure to urine or stool. How do we prevent? How do we manage peristomal MASD? The pouching system is your number one protection, because what does the pouching system do? It should protect the peri-wound skin and effectively contain the urine or the stool. So I've got it, if I have a patient with a problem, I have to go back and look at the pouching system. Do I have a good fit? Is the opening sized correctly? Do I have drainage tunneling under my pouching system? So I've got to look to see that the patient's in the right pouching system, that I've got a good fit, that the drainage goes into the pouch and not under the pouching system. I've got to make sure that the patient knows how to measure the stoma and how to size the opening in the pouching system correctly, especially if they have an ileostomy with small bowel output. I want to protect any exposed skin with something like barrier paste or a barrier ring. I've got to teach the patient to change the pouch at appropriate intervals. So I don't want them to just tape the outside edges with pink tape so they can get 2 more days. If the pouch is leaking on the inside edge, I want them to take it off and put a new pouching system up. And I want to teach them the crusting procedure, which is sprinkle on ostomy powder, dust off the excess, and if necessary, spray with an alcohol-free barrier film so that they know how to manage areas of breakdown. We're going to stop there and take a break. And when we come back, what we're going to talk about is full thickness skin damage caused by pressure or a combination of pressure and shear. Big difference between partial thickness and full thickness lesions. Partial thickness lesions are top-down injuries that are caused by friction, shear, moisture exerted against the skin surface. Pressure shear injuries are typically full thickness lesions that are caused by tissue ischemia and that start from the bottom up. Okay, take a break. We'll come back.